Now I request PC Manoria, if you're ready, you can go ahead with your presentation.
Now, in everyday practice, we see patients of acute myocardial infarction, and the purpose of this presentation is just to highlight what are the high-risk group. For example, every day we see patients with acute inferior myocardial infarction, although we first decide whether this is due to a right coronary occlusion or due to a left circumflex, and this is very easy. If the ST segment elevation is more in L3 compared to L2, this becomes a right coronary occlusion. Here you can see this is circumflex occlusion. The ST segment is more elevated in L2. And the second thing is there is ST segment depression in AVL with right coronary artery inferior infarction, whereas the T is upright in L1. But this does not differentiate whether the inferior infarction is a high-risk subgroup. What is important is that you should, all patients with inferior infarction, record the right-sided leads, because if you have right ventricular infarct, which is associated with inferior infarction, as happens with proximal right coronary occlusion, this becomes a high-risk group. Now, can you switch off the lights? Now, if you look at this ECG, there is inferior infarction. This is right coronary artery disease because the ST segment is elevated more in L3 compared to 2. You can also see the ST segment depression. But what is important that in all patients with right coronary artery inferior infarction, you should take a right-sided leads. And you can see these right-side leads are showing marked ST segment elevation, and if the ST segment elevation is more than 1 millimeter in V3R or V4R, this amounts to associated right ventricular infarct. And whenever there is associated right ventricular infarct, the lesion is obviously in the proximal right coronary artery. As you can see, this is angiogram from one of our patients. You can see cut off right in the proximal portion, and this is the frozen picture, and the angioplasty has been done. You can see the right coronary. So one of the high-risk group of ACS is inferior infarction, right coronary artery, when it is associated with a right ventricular infarct. And there are several reasons. You can see the mortality with inferior infarction with RV maybe 25 to 30% compared to the usual 4 to 5%. And these patients are in shock, and they do not respond to the usual conventional vasopressors. They respond to IV fluids. AV blocks are more common, and scar-related VT is more common. So it is mandatory to pick up associated right ventricular infarct whenever you have an inferior infarction, and that is very simple. You can just look at the right-sided leads and can. Now, this is not actually a high risk, but it's important to understand that when you have an occlusion of the posterior branches of the circumflex, they may manifest as ST depressions in V1, V2, V3, so that if such a ECG is presented before a physician, this may also be diagnosed as non-ST elevation MI in the LAD territory. But whenever you have these changes, you must take the posterior leads, and if you take the posterior leads, you can see here there's ST elevation V70, V89. So clearly this is circumflex disease, the OM2 branches occlusion, which is producing a posterior infarct, and this should always be done whenever you have this. Another high risk infarct with the inferior infarct is when you have reciprocal changes in the precordial leads. V1 to V3 is compatible with inferior infarction, but if you have ST changes in V4, V6 indicates an associated circumflex or LAD vessel feeding from the right collaterals to the right coronary artery, and therefore any ST depression in V4 to V6, and if it is also showing decreasing pattern, then the prognosis is better. But if the ST segment is progressively increasing from V4 to V6, this also becomes a high risk case. And this is another way to find out the extent of inferior infarction. The ST segment is elevated more than 7 millimeters. This means inferior infarction. Now, when it comes to the question of anterior infarction, one must always pick up a proximal LAD disease because this is a very high subgroup. And in anterior infarction, what you must remember that although we diagnose anterior infarction by the precordial leads, very important to look at the inferior leads. If the inferior leads shows ST segment depression, this becomes a proximal LAD disease, again a very high risk group, patients more chances of going in cardiogenic shock and should be referred for angioplasty. But if it is a distal LAD, you can see there is ST segment elevation in the inferior leads. So the first thing whenever you see a pattern of infarct in the anterior leads, make sure you look at the inferior leads, and the inferior leads show ST segment depression. This becomes a proximal LAD disease. And the reason for this is that the vector in proximal, you get a big infarct, the vector is directed superiorly, and that's why you have ST segment depression down. Now, in proximal LAD disease, if it is before the septal artery, you also get a right bundle branch block, which again becomes a very high risk subgroup. So, associated right bundle branch block with anterior infarction, ST segment elevation more than 2.5 in V1, and this elevation obviously more than AVR. So this is again a very high risk group and should be submitted for angioplasty. Now this is another ECG from a patient of anterior infarction. You can see that there is infarct in the anterior leads, but the ST segment is markedly elevated in 1 in AVL. And this is after the septal branch. This again is a high risk infarct. As you can see here, the vector is directed towards AVL, ischemic vector, and therefore you have ST elevation in 1 in AVL in association with an inferior infarct. And this is also a very high risk group, and you can see the site of block after the septal artery. Angioplasty was done, and you can see marked settling of the ST segment. Another thing which characterizes a high risk infarct is the grade of ischemia. Grade 1 is tall peak T, grade 2 is ST elevation, and if there's distortion of the terminal segment, as you can see here, or if the ST segment is markedly elevated, tombstoning, this also becomes a very high risk. These patients, there's also ischemia of the Purkinje fibers, they are damaged, they may not respond even to primary angioplasty. So such patterns are also very high risk, and you must always pick up these patients and try to revascularize them at the earliest. This is, of course, if you have an anterior infarction, if the ST elevation in lead V1 to V6 greater than 12 millimeters. Now, LBB with anterior infarction is also a high risk group, but more because of comorbid conditions. And whenever you have an LBB, you must try to find out whether it's associated infarct or not. And usually we diagnose by the Garbosa's criteria. I'll show you one ECG. The first thing which we do is that if there's ST segment elevation more than 1 millimeter in a lead with concordant T wave, or ST segment elevation in leads like V12, but it has to be more than 5 millimeter, or ST depression in V1 more than 1 millimeter, all these are indicative of associated infarct. We have the revised Garbosa's criteria in which a ratio of ST segment elevation to S is calculated, and if it is more than 0.2, this has a more sensitivity and specificity than the conventional criteria. Yes. Now, another high risk group in acute coronary syndrome is this. If you have diffuse ST segment depression, here more than 6, 7 or 8 leads, you can see ST depression, ST depression, ST depression, ST depression everywhere. And if you look at AVR, there's ST elevation. Now this is left main stem disease or a very proximal LAD. And if you get such an ECG, the patient pain may get subside after conventional treatment. These patients should be submitted for angiography at the earliest and revascularized because they may develop acute occlusion anytime, and if it develops, it's going to be going to be fatal, or they may be in cardiogenic shock and may not survive. So this you must pick up the left windstem disease, and the criteria are very simple: diffuse ST segments in more than 8 leads, and AVR, the ST segment is elevated. Now this is another electrocardiogram which we see in day-to-day practice. The patient develops acute chest pain, his chest pain disappears, and when you take ECG, it shows T-wave inversion in V1, V2, V3, and this occurs because of occlusion of the left anterior descending. There is total occlusion. First, it gets sliced spontaneously, and there's a tight LED stenosis which is seen in these patients. So even if the chest pain has suppressed, these patients must be submitted for angiography and revascularized, because there's an increased risk of subsequent anterior STEMI within the next 2 to. So this is again a very high risk proximal LED lesion, where the patient gets chest pain will disappear, and the ECG later on show these changes. Another thing you must remember is the circumflex vessel is one of the vessels which is notorious that it may not show any changes in the electrocardiogram. So if you have a patient with prolonged ischemic chest pain like this, persistent normal ECG, but if you take an angiogram, you can see this total occlusion. This also should be kept in mind. So these are various reasons why circumflex does not produce any changes many times. So although ECG is very useful in our day-to-day practice, you must recognize the high-risk group so that these patients can be submitted to revascularization the earliest. And some of the high-risk groups are an inferior infarct, right coronary artery disease associated with the right ventricular infarct. You must pick up, the mortality is very high. The second subgroup is an inferior infarct with ST subdural depression in V4 to V6, which indicates an associated LAD or circumflex disease, and in anterior infarct, ST segment depression in the inferior leads, again, is a very high risk group. Associated right bundle branch block in anterior infarction is again a very high risk group, and LBB with anterior infarct is also a high risk group. And if you have marked distortion of the terminal portion of the QRS, as I have shown you, again becomes very high risk group. And the diffuse ST segment depression in most of the leads with AVR ST segment elevation becomes a left main stem disease, again a very high risk group. And ST depression or T-wave inversion in the proximal, in the V1 to V3, again is a proximal LAD lesion, so-called the Wellen syndrome, again a very high risk. So although ECG is very useful, you must be able to pick up whenever you see an electrocardiogram of a patient with acute coronary syndrome, this is a high risk group. You must understand the prognosis and try to revascularize these patients. Thank you very much.
Thank you, thank you, sir, for the nice and brief description. We say ECG is a poor man's angiogram.
Yeah.
So it's right, you have given the saline futures, how we can suspect the future ACS.